secondary dairy hyperaldosteronism. Okay, and over here I'm going to give you more examples. But secondary means that the tissue itself that produces aldosterone is okay, but it is stimulated some secondarily by other hormones, and this turns into increased levels of aldosterone. Okay, and the first disease what I'm going to mention, and it's again a detour but a very important one, is Cushing's disease. Okay, and what is Cushing's disease? Can you tell me? So first example is Cushing's disease. And this is crucial for you, lethal question. So Cushing's disease, what is Cushing's disease? Can you tell me? Where's the main problem? What's that?
Thyroid?
I'm sorry?
No, I don't remember.
A problem with ACTH?
Very good, very good. And please, from today, remember Cushing's disease, the villain that makes the metabolic changes. So it makes you to have hyperglycemia, that you're going to have proteolysis, that you're going to have moon phase, you're going to have hump, buffalo hump, or what do you call that? You're going to have cataract, you're going to have glaucoma, you're going to have belly, like a ovoid, like fat belly, and tiny extremities. It's cortisol. Okay, so what I really would love you to remember and combine it is that if I say Cushing, first of all, you should imagine increased levels of cortisol. Cushing is talking about cortisol. Okay, but why are we mentioning it under secondary hyperaldosteronism? It's sort of a byproduct. It's by effect, like collateral effect, that also aldosterone is going to be increased. And still, one important comment. There's a big difference if we say Cushing's disease, and over here we care a lot, versus syndrome. And this is so special. And it's also different. The American view and European or German and Czech view, and on these two terms. Okay, I'll tell you the differences. So watch out. Cushing's disease, and this is the same over here as in the US. It's only one thing. Cushing's disease is increased ACTH levels produced by. This is a hypothesis by the adenoma of pituitary gland. Okay, it's the anterior part. Okay, and this produces, so over here you got an adenoma, and this produces ACTH in high levels. It's a benign tumor, so it won't metastasize. Okay, but the production is autonomous, so you cannot control this. And typically it's not in such a high levels, like suddenly, but it goes up and up and up, and you're looking more and more Cushingoid, as I described. You're having a moon phase, etc. Okay, but as I said again, although the trigger is ACTH, the main villain that changes these are adrenal glands, and the high levels of ACTH, I'll put more levels, they both stimulate the glands to hypertrophy and produce everything more, not only cortisol, but that's the main one, cortisol, but also aldosterone. That's why you can put it under secondary hyperaldosteronism as well. And also sex hormones. And don't forget, there are many over here. There are many enzymes, and everything is made out of cholesterol. Okay, so there are many MIT products which are also released, and some of them can bind to aldosterone receptors. Some of them can bind to cortisol receptors. Okay, so that's why it's like boosted up, and you have lots of glucocorticoid, or you have some, let's say, you could say modification of these hormones, which are also have glucocorticoid activity as cortisol, or mineralocorticoid activity as aldosterone. Okay, and also not only this, but it's been shown in vitro, but very likely it works in vivo. Doesn't matter what is the reality now. For you, what matters is to remember the people with increased cortisol, and you have lots of cortisol, also cortisol can bind to aldosterone receptors, at least on cell cultures. Okay, but very likely this works in reality as well, and that's why high levels of cortisol can have mineralocorticoid effect. That's why typically people with Cushing's, they have hypertension, and they can have hypokalemia and metabolic alkalosis as well. Okay, yeah. So there are many ways how the aldosterone is, let's say, taken account in Cushing's disease. But mainly, remember, Cushing's disease is all about cortisol. That's the main villain. Okay, so hyperglycemia, etc. So that was Cushing's disease. Okay. And you can put that beautifully under secondary hyperaldosteronism. But what is then syndrome? And what is the most common cause of syndrome?
The high cortisol levels.
By what?
By just released from the cortisol from the cells.
Yeah, but can you give me like why it is?
Like Sharon said, some.
The autonomous release of cortisol increased from cortex of the adrenal gland. This is rare, but it's a good example. But the most common cause of Cushing syndrome is iatrogenic, that you're giving a prednisone to people. Okay, this is the most common cause, iatrogenic.
Retrogenic?
Iatro, why means by cure, that you're giving drugs as a doctor. It's made by doctors, okay? Iatrogenic means that you're giving cortisol to someone in such a high doses that you're going to cause Cushing syndrome. And this is very common. Very common because for what do we use prednisone? For any autoimmune disease, okay? So if I'm losing kidneys because of autoimmune diseases, you're going to give me prednisone in really high doses. And although we don't know exactly the effect, how it works, we know that it's going to blunt the process, okay? So we're sort of, killing much worse process with pretty bad one. That means that you're going to have Cushingoid problems, but that's the only way how to stop many of the autoimmune diseases. Okay, so if someone has rheumatoid arthritis or whatever, you give them prednisone. Okay, so and that's why it is so common. That's why there's so much that's why we use so much prednisone, and that's why you can have very easily Cushing's syndrome out of it. And basically, remember from now on, if someone says I'm having Cushing's disease, which is over here, okay, it tells you right away I'm having an adenoma, and they're gonna do a surgery of my brain. But if someone tells you I'm having Cushing's syndrome, there are so many causes that can cause this. Okay, but the most common one very likely is iatrogenic, and so that's okay. But there's a very awful cause of Cushing's syndrome, and that is a malignant tumor. And you know what? It's a tumor coming out of lungs, And this tumor, although it's malignant, and also from now on, remember, in most cases, if the tumors are malignant, they don't produce so well functional hormones, because as they're just mutated, their DNA is destroyed, and more likely the products they produce are like crappy, okay? But not in this case of the malignant tumor. It's called small cell carcinoma. It's somewhere in the lungs. It is very malignant, but small cell carcinoma, or in other words, oat cell carcinoma, older term, oat cell. And this guy, although very malignant, very, very malignant, is able to produce, in some cases, high amounts of ACTH. In some cases, ADH and other molecules. Okay, so watch out. So this guy is very malignant, but still works efficiently and produces nice molecules that are functioning in some cases, not always. Okay, but look at this. This is a ectopic production of ACTH. That's why we are not calling it Cushing's disease, but we're calling it Cushing syndrome. Okay, yep. So, and of course, if the ACTH is high enough, again, it will stimulate the adrenal cortex. You will have increased levels of cortisol, and you will have Cushingoid habitus. But and also it can stimulate increased levels of aldosterone. So that's why you put it nicely under the Cushing's, under the secondary hyperaldosteronism as well. They will have hypertension. But unfortunately, the small cell carcinoma is so fast, and sometimes the levels are really like high of the ACTH, basically, and it can kill you also very fast. So the changes are not so obvious in terms of, let's say, appearance, and typically you find that pretty late with the patient. Okay, so or I'll still explain it more. But anyways, so you can have Cushing syndrome due to iatrogenic, due to cortisol intake, due to small cell carcinoma, remember that, and also due to cancer of the adrenal cortex, as you said. Okay, so there could be a tumor of the, or carcinoma, and it could be also benign, but in these cases it's many times and commonly malignant, but also produces cortisol. Okay, so you can have a tumor of the cortex. Okay, so that would be over here. If I put cortex and lungs, so there's an awful tumor here. And why I am mentioning is, first of all, you should really know the difference between Cushing's disease and syndrome. And watch out, in the US and in Wikipedia, they have a big group, and this is logical, by the way. They have a big group of Cushing syndromes. And one of the subdirectories of Cushing syndromes, they call Cushing's disease. Okay? Yeah? Get it? So in Wikipedia, don't call me because of that, or don't write me. It's the, let's say, different classification that is used in the US, for example. So and it's logical. You have one big group of syndromes, Cushing syndrome, and that accounts any cause of increased cortisol. So they put Cushing's disease under the syndrome. But in Europe, endocrinologists still, it's a historical thing, and they want to have Cushing's disease separate from the Cushing syndrome. So watch out, it's not wrong in Wikipedia, it's just a different way how to it's different system. Okay, yeah. So
Do we put under the secondary hyperaldosteronism or not?
So, and under secondary hyperaldosteronism, you can easily put Cushing's disease, small cell carcinoma, where the ACTH is increased. Okay, yeah, okay, yeah. Maybe the tumor can produce some aldosterone as well, so then you put it there too. Okay, in a way, but maybe in a way, you wouldn't, okay, this you wouldn't call secondary hyperaldosteronism because that would be then primary, okay? Yeah. But over here we're talking about carcinoma, and the, let's say, primary hyperaldosteronism is talking about benign tumor producing aldosterone. Over here okay, watch out. Over here I detoured and I talked about Cushing's disease versus syndrome. And beautifully over here, under secondary hyperaldosteronism, you can put Cushing's disease. I will mark it. Definitely this, and definitely, for example, where the ACTH is increased. Okay? Yep. So we are under secondary hyperaldosteronism. And this could be misleading, because when I normally only mention ACTH increased, everyone then, when they talk about Cushing's disease, they talk about aldosterone. And that's why I want to explain right from the beginning, watch out, don't do that. Cushing's disease or syndrome is about increased levels of cortisol, and the aldosterone, it's just a byproduct. Although you can mention that in secondary hyperaldosteronism, okay? It's also a cause. But don't never confuse aldosterone and cortisol. Cushing's is cortisol. Cushing's is cortisol, okay? And one more question. This is pretty important. You're going to be in your office and someone comes with a moon face. What do you ask him first? And we don't know the mechanism of moon face. We don't know exactly how it comes that if I'm having increased levels of cortisol, why my face gets swollen. But after this class, just Google it out. How does a moon face look like? But when someone out of your family or one of your patients comes, and now suddenly he has a moon face, what will be your first question? And the question is, are you on prednisone? And if he says yes, you're going to be so happy, okay? Because the other reasons of moon face don't have such a good future, okay? Especially if it's a small cell carcinoma. So it's first you want to exclude, or you want to hear that it's because of the treatment of something else, because the other options are not too good, okay? Small cell tumor of the cortex producing cortisol, and except the iatrogene, maybe the best would be Cushing's disease because it's a benign tumor. They know how to do the surgery well, so in case the surgery is done well, you're saved. Okay? Okay? So this was Cushing's disease, which you can mention under secondary hyperaldosteronism, please. Okay? Yep. And it's because this main problem is here, but you release also increased levels of aldosterone. Okay, so they will have hypertension as well. They can have typically people with Cushing's disease, they have hypertension. Okay, to it they have diabetes because cortisol is increased. Okay, yeah, and also they can have decreased levels of potassium and also metabolic alkalosis, for example. Yeah, and other kinds of ABB changes, but metabolic alkalosis you can mention as one of the changes that is going on there. And typically there are several changes of, let's say, ABB that they can come together. Okay, watch out. You can mix many ABB changes. Yeah. So that was Cushing's disease. So another example of secondary hyperaldosteronism is renovascular hypertension. And by the way, still Cushing's, and these people will have hypertension, as I said. And what type of hypertension is that? Secondary, yeah?
Yes, because we know the cause.
Yes, exactly, secondary. Okay, and if we get here, this is also beautiful example of secondary hypertension. Okay, so and it's renovascular hypertension, so it's secondary hypertension. So again, it's the very rare group, 5% of the rest. Okay, so and over here I'm going to draw a abdominal aorta. These are the renal arteries, I'm sorry. Okay, and those are kidneys. And here's the left kidney, here's the right one. And this left one has a narrowing over here. And the narrowing could be whatever. I mean, yeah, it could be a clump, it doesn't matter. But the most common cause of narrowing of this artery is atherosclerosis. So as you get older, it gets the atherosclerotic plaques, they grow there, and they're blocking the artery. And what happens? Well, what the left kidney thinks, oh, I'm not getting enough perfusion. My perfusion is decreased. So what? Let's boost it up. I need higher pressure. Well, an RA axis is activated. So basically the left kidney tries to normalize the pressure over here. But unfortunately, by boosting up this vasoconstriction, sodium resorption, and water,
basically the auto-regulation of the kidneys kind of kill the kidneys.
Yes, exactly. Okay. The other kidney, you will kill because the left kidney boosts up the pressure because it wants to have a nice perfusion, and this kills the other kidney because the other kidney is having hypertension. And also brain and everything else. So everything is having hypertension, and the heart has to now pump higher. Okay, so this is another example of renovascular secondary hypertension, and also secondary hyperaldosteronism. Okay, yeah. So renovascular hypertension. Well, and then you have another example, and it's reninoma. So again, reninoma, rather benign, it's a benign tumor, but producing high levels of renin. And of course, this again boosts up all of these, and you're having secondary hypertension plus decreased potassium plus metabolic alkalosis. Okay, so these are three examples of secondary hyperaldosteronism. And I'll give you still one more, and this is very important. And I'm going to make a barrier over here because this one is a bit different, and you'll tell me why it is different than the other ones. And this is sort of a physiological response. It's a compensatory response to any hypotension. So if I'm having a acute hypotension or chronic hypotension by whatever the cause, I will have this response, and this will trigger also secondary hyperaldosteronism, okay? Because I'm just having hypotension. So if I'm having hypotension, also my kidneys are not having enough of perfusion, and they will boost up the RA axis. And it could be sudden, like if you're bleeding or whatever, but this is like maybe not as good example as chronic decrease of pressure. And guess when you have decreased pressure? For example, when you have left ventricular failure. So when the left heart is already failing, you're not able to keep the blood pressure as it should be, and it goes lower and lower. And when it goes slow, the kidneys are boosting up the RA axis. Okay, so this is an example of, again, secondary hyperaldosteronism. So the kidneys are boosting up RA axis. So basically, it's a normal response as you are used to and happens to you all the time. When you're hypotensive, RA axis is triggered on. But unfortunately, in case of left heart, you don't want that, because the body is like designed for like like that everything is functioning as it should, okay? And when something starts to fail, it totally collapses. Because what? If I'm having a left heart failure, I don't want to have fluid overload. But unfortunately, that is what the RA axis does. You retain water, and if I'm having left heart failure and maybe already failing with the right heart, I'm having edemas now, and the boosted RA axis will only worsen the edemas. That's why first and immediate therapy for left heart failure is to getting rid of the fluid. So you will block the retention of water. So you'll give them, that's why you're giving them diuretics and everything to get rid of the excessive water, okay? Because you wanna put the weights down that the left heart has to wait all the time, okay? That has to work against. But apart from this, so everyone understands how this type of secondary hyperaldosteronism is working, okay? So in a way, it's a physiological response, but unfortunately in not good times when my left heart is already failing, okay? And there's a difference compared to the other ones. Will there be hypokalemia? Well, there's going to be hypokalemia. You're getting...
So it won't be metabolic alkalosis though, right?
Well, no. Watch out. There will be metabolic alkalosis. But if I'm getting ischemic, there's going to be also buildup of lactate. So there's going to be combination of metabolic alkalosis because I'm peeing out H+, but also lactate buildup, so metabolic acidosis. You can combine. You describe different ABB disorders and you put them together, okay? Yeah? And we're going to learn this in ABB lecture. But look at this. So H+ is going down too. But there's one difference. Who will tell me this difference? In this case, will I have hypertension?
No.
No.
I mean,
because I'm fighting the hypotension. I'm trying to normalize the tension, okay? So basically, watch out, turn off the other speakers or whatever. But anyways, in this case, I'm going to have sort of normal blood pressure, okay? Or a bit lower. Depends how severe is the drop of the blood pressure originally. So I'm trying to just normalize the pressure by this. So over here, this is an example where you will have no secondary hypertension, okay?
you are blocking the if you are the aldosterone is increasing to compensate that low blood pressure, right?
Yeah.
Because there is cardiac output since the left ventricle is failed. So in that case, we are reabsorbing more sodium and water.
Yes.
Why do we want to cause diuresis then?
Yeah, because you don't want to resorb more water, and because you're gonna still even more overload the heart. Okay, you're gonna stretch it more, and it will just give up at the end. So basically, you rather will put some beta blockers to slow down the heart, to calm down, and you don't want to. With this overload, which is done by RA axis, it just worsens the situation. Okay, yeah. Good. Okay, so these were examples of increased aldosterone. Okay, and let's get to examples of decreased aldosterone. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.